Welcome to session 22 of the Simple course. In the first part of this session today, we will review a theory explaining dissociation called the structural dissociation theory. In the second part, we will begin to consider principles of the treatment of traumatic spectrum disorders. You watched the two introductory videos entitled What is Dissociation and 9 Signs You Have Unhealed Trauma. Please go to session 22 on the website. It's simple2021.com. Next are our usual reminders directed mostly at people doing the course in a group setting. Please take a few moments to read these on your own. To watch this week's mindfulness practice video entitled Mindfulness-Based Stress Reduction, please go to the website now. For people doing the YouTube course as part of a group, you can now pause for questions, comments, or feedback. Let's quickly name some of the topics we've previously covered in the Simple course that are important when we're considering dissociation. In the course, we have already discussed stress and the stress response, adult, developmental, and attachment trauma, how to assess trauma, consequences of trauma, the ACE studies, implicit and explicit memory, how autonomic activation explains the trauma spectrum disorders, and psychiatry's blind spot for trauma. Today, we will continue our consideration of the effects of trauma on people. We will start with a review of the material introduced in session 22 of the Simple Manual. Dissociation is explained by the structural dissociation theory, which describes primary, secondary, and tertiary dissociation. After that, we will consider principles in the treatment of dissociative and trauma spectrum disorders. At midway point, we will take a break, and we will have our usual time for discussion. Before we start, please take a moment to consider how you're doing with the course's homework. Can you remind us what dissociation is? In its colloquial use, the term dissociation describes a disconnection between things usually associated with each other. In psychology, dissociation refers to a wide array of psychological experiences, ranging from a mild emotional detachment from our immediate surroundings, such as happens when we're driving long distances, to more severe disconnection from physical and emotional experiences. The major characteristic of all dissociative phenomena involves a detachment from reality, rather than a loss of reality, as is the case in psychosis. The extent of dissociation lies on a continuum or spectrum. In mild cases, dissociation can, in the presence of stress, be a healthy coping mechanism. Daydreaming is a benign example of mild dissociation. Towards the pathological end of the dissociative spectrum are the DSM dissociative disorders. The DSM-5 lists 4 dissociative disorders. 1. Dissociative identity disorder. 2. Other specified dissociative disorder. 3. Depersonalization/derealization disorder. And 4. Unspecified dissociative disorder. The DSM doesn't make an explicit link between dissociation and the trauma spectrum disorders. ICD-10, the International Classification of Disease, 10th edition, an alternative to DSM classification, which is used in Europe, also lists, in addition to the 4 DSM dissociative disorders, a 5th dissociative disorder of movement and sensation. This includes paralysis, unexplained pain, and other sensations, and pseudoseizures. In the DSM, These symptoms are called conversion disorders and considered a somatoform disorder. As we will see when we consider dissociative identity disorder, dissociative experiences are sometimes not integrated into the usual sense of self, resulting in discontinuities in conscious awareness and memory for these experiences. Psychological dissociation refers to the disintegration of nervous system functions that are usually integrated. In people in whom these functions are integrated, information flows freely between the information centers we learned about when we reviewed the developmental maturational model. These are the somatic, emotional, rational, and self-observing centers. Each of these information centers, or minds, can, however, become disconnected or dissociated from the others. The prototypical type of dissociation is seen in the hypofreeze activation state, which in soldiers has been described as the 1,000-yard stare. In this activation state, the self-observing, rational, and higher levels of the emotional mind shut down, and the reptilian mind, responsible for basic life functions, takes over. There are, however, many other less dramatic forms of dissociation. For instance, being hyperrational can be a form of dissociation in which the emotional and self-observing minds shut down and the rational mind takes over. This type of dissociation is commonly used by avoidantly attached people. Dissociation presents in a variety of different ways, which include 1. Identity confusion, which is an inner struggle about one's sense of self and identity. 2. Amnesia, which presents as memory loss that is often described as losing time. 3. Depersonalization, which is feeling disconnected from your own body, mind, or self. 4. Identity alteration, or a sense of acting like a different person some of the time. And 5. Derealization, or feeling disconnected from the world around you. Are there theories about what dissociation is and why it happens? Structural dissociation theory is a psychodynamic theory that's over 100 years old. It was first proposed by French physician and philosopher Pierre Janet. It is one of the theories about dissociation that still makes the most sense. Let's briefly introduce Pierre Janet. Pierre Janet lived from 1859 to 1947. That made him 3 years younger than Freud. He trained as a psychologist, physician, and philosopher. Like Freud, he studied under Jean-Martin Charcot at the Salpêtrière, a large Parisian hospital. He was one of the first to draw a connection between a person's past trauma and their present-day symptoms. He also coined the term dissociation. Freud acknowledged his debt to Janet. Janet doesn't get as much credit in modern psychology as Freud because, unlike Freud, he wasn't self-promoting. Structural dissociation theory is based on Janet's work. In the late 1980s, Ehlert, Nugenius, Arno van der Hart, and Kathy Steele built on Janet's work and expanded structural dissociation theory. So what is structural dissociation theory, and how does it explain the trauma spectrum disorders? According to the structural dissociation theory, post-traumatic stress disorder, complex post-traumatic stress disorder, and dissociative identity disorder, formerly known as multiple personality disorder, are all related dissociative disorders. Structural dissociation theory proposes that patients with these complex trauma-related dissociative disorders experience a division of their personality into different parts, with each part having its own psychobiological characteristics. According to structural dissociation theory, these 3 types of dissociation occur on a continuum with no clear dividing lines between them. Symptoms from the different types can be present in one person. 1. Primary structural dissociation is PTSD. 2. Secondary structural dissociation is complex PTSD. 3. Tertiary structural dissociation is dissociative identity disorder. The type of dissociation that develops in a person depends on the balance between the duration and severity of the trauma and the person's coping resources. Can we review how dissociation arises from trauma? Recall the arousal curve in which we have hypoarousal, hyperarousal, and the window of tolerable emotions. Outside that window is the hyperactivation, of which hyperfreeze or the orienting response and fight or flight are both features. Also outside that window of tolerance is hypoactivation, which occurs in depression or dissociation. As Stephen Porges describes in his polyvagal theory, hypofreeze type of dissociation occurs when the dorsal parasympathetic nervous system's handbrakes go on and the organism goes into feigned death, in which the heart slows down, as does respiration and virtually every other bodily function. In this dorsal parasympathetic activation, the organism goes into the reptilian brain mode. This hypofreeze response occurs under extreme life-threatening circumstances. If the organism goes into hypofreeze and is able to escape, then the arousal state may be a one-time event. If, on the other hand, the organism goes into hypofreeze and is unable to escape but survives nevertheless, the hypofreeze state of arousal may become an implicit memory, which resurfaces periodically as one of the three dissociative spectrum disorders. When a person faces a stress, the typical response is to cope, fight back, or run away. That's the fight or flight response. When the stress appears to be life endangering and physically inescapable, and fighting back or fleeing are not options, then all that's left is escaping mentally by shutting down the rational and emotional minds and fleeing into the reptilian mind. That escape leaves behind an unprocessed emotional memory of the trauma, which is stored in a file in the emotional mind's implicit memory. PTSD symptoms of hypo and hyperarousal, such as flashbacks and dissociation, can be seen as this implicit memory file opening suddenly while the person is trying to carry on with ordinary daily function. When this file opens, they emotionally relive the trauma. To use a computer metaphor, a traumatic dissociated experience is like a computer file that is saved into the computer memory and no longer an open window. Triggers reopen the file. This unprocessed dissociated traumatic memory typically pops up in the screen of the mind, either spontaneously or when triggered by something that resembles the original trauma event. The presence of these associated traumatic memories gives rise to the trauma spectrum symptoms, which include intrusive memories, startle response, shame, self-hatred, panic attacks, chronic pain, headaches, eating disorders, substance abuse, self-destructive behaviors, depression, irritability, loss of interest, insomnia, decreased concentration, hopelessness, nightmares, and flashbacks, among other symptoms. You said there are primary, secondary, and tertiary dissociation. What are they, and how are they different one from another? Let's start with primary structural dissociation, which can be used interchangeably with post-traumatic stress disorder. Structural dissociation theory recognizes that humans have emotional and rational minds, which ordinarily are integrated. One freely exchanges information with the other. Structural dissociation theory postulates that trauma splits or dissociates personality into two components. System 1, or the emotional mind, protectively splits into two parts. One, an apparently normal part, or ANP, that tries to carry on with the usual business of life. And two, an emotional part, or EP, which is mostly concerned with defense and survival. This dissociated emotional part carries the unresolved and unprocessed trauma and episodically emerges as flashbacks and dysregulated emotions, including fight, flight, freeze, and fawn. At times, the person functions mostly in their apparently normal part. At others, the traumatized dissociated emotional part takes over. As we will see when we discuss internal family systems, emotional mind, emotional parts, and part selves are identical. According to structural dissociation theory, the apparently normal part belongs to the daily life action system. The emotional part belongs to the defensive action system. These two systems have different functions. The apparently normal part carries on with normal daily life tasks such as work, study, play, sleep, eating, doing housework, socializing, caring for children, etc. The emotional part, on the other hand, is charged with survival. When activated, it fights, flees, goes into hypofreeze, and after the threat has passed, recuperates from it by resting, isolating, and caring for physical or emotional wounds before returning to daily activities. Is structural dissociation theory's emotional part the file that's created by trauma and stored in implicit or emotional memory, and that occasionally pops into the computer screen of everyday life? Yes, and that file popping into the screen are the symptoms of PTSD, including flashbacks. It's important to note that there are several different types of flashbacks. Flashbacks are a common experience in people with trauma spectrum disorders. The common perception of a flashback is that it is the re experiencing of the trauma as a visual image. There are, however, at least three distinct types of flashbacks. One, visual flashbacks, where the trauma is re experienced as a visual image. Two, somatic flashbacks, where pain and body sensations are felt due to the re experiencing of the physical pain of the trauma. And three, emotional flashbacks, where the intense emotions felt during past trauma are re experienced. While people with PTSD spectrum disorders often associate visual flashbacks with their trauma, they may not as readily associate somatic or emotional flashbacks with that trauma and are often at a loss as to how to explain them when these flashbacks occur. Are there other features of primary structural dissociation, also known as PTSD, that are important for us to know? People who have experienced trauma are at a much greater risk for other issues such as substance abuse, suicide, depression, sexually transmitted diseases, and unemployment. PTSD is different in women and in men. 10% of all women develop diagnosable PTSD compared to only 4% of all men. Women are at a much greater risk of sexual assault or abuse, child abuse, and domestic violence. Risk factors to develop PTSD include genetic predispositions, lack of social support, neurological impairments, previous trauma, pre existing mental health conditions, and significant life stressors. The post traumatic stress disorders are often misdiagnosed as mood, anxiety, and personality disorders. There is a significant overlap between symptoms of post traumatic stress disorders and ADHD. Both can present with easy distractibility, difficulty listening, disorganization, hyperactivity, restlessness, and difficulty sleeping. For people suffering from trauma spectrum disorders, reminders of the trauma can trigger the emotional part. Because of this, the apparently normal part tries to avoid them. With time, in order to prevent triggering the emotional part, the person avoids more things and becomes more phobic. Eventually, many people with trauma spectrum disorders become housebound. As their life becomes more restricted, they become more disconnected from others, a meaningful occupation, engagement with the world, nature, and a meaningful cosmic story. This can lead to depression on top of the PTSD. The avoidance of potential triggers and memories perpetuates PTSD, since the processing of the implicit traumatic memories in the emotional part requires some degree of controlled exposure to triggers and or traumatic memories, even if they are recent reenactments. People remain victims of trauma rather than becoming its survivors. The more avoidance there is, the less the apparently normal part is able to maintain a semblance of apparent normality. How trauma impacts people depends on their resources. At one end of the resource spectrum are people with secure attachment, with a healthy sense of self, ability to have healthy relationships, and to self soothe, and who have normal psychosocial development prior to the single event trauma. They have more resources and are less likely to develop PTSD. If they do, their prognosis is better. At the other end of the resource spectrum are people with insecure forms of attachment and attachment/developmental trauma, with an unhealthy sense of self, trouble with relationships, and with self soothing. These people are likely to have psychosocial developmental issues. They have fewer resources and are more likely to be re traumatized and to experience the more severe types of post traumatic spectrum disorders. Are you saying that the type of parenting a person receives plays a role in their predisposition to developing PTSD? Yes, there are three main ways by which a parent or a caregiver's trauma can impact a child's development. One, epigenetically. We have already discussed this and won't repeat that discussion here. Two, the mother's hormones, especially cortisol, can affect the baby's development in the womb. And three, PTSD and its accompanying emotional dysregulation in the parent impacts the parent-child attachment style. A person who had a caregiver with untreated PTSD may therefore be more prone to PTSD themselves. They may also struggle with relationships and their repair and be more likely to experience emotional dysregulation. If primary structural dissociation is PTSD, what is secondary structural dissociation? Secondary structural dissociation is also known as complex PTSD. On the spectrum of structural dissociation disorders, it is more severe than primary structural dissociation or PTSD. Secondary structural dissociation is often associated with insecure types of attachment and developmental trauma. Children and adults with insecure attachment are more vulnerable to trauma and more likely to experience multiple traumatic events. As with primary structural dissociation/PTSD, in secondary structural dissociation, an apparently normal part tries to carry on with normal everyday life. But in secondary structural dissociation, because there may have been multiple traumas and or an increased vulnerability, there are multiple split off emotional parts, each arising from a different trauma and each carrying different implicit memories. These are the multiple dissociated traumatic complexes arising from the multiple traumas. These traumas may have happened at different ages and stages of development, and the trauma that gave rise to them may not be a discrete one-time event, but ongoing over a significant time period, as in ongoing child or partner abuse. As we will see when we talk about internal family systems, it's useful to think of these emotional parts as having distinct personalities, ages, ways of thinking, feeling, and behaving, as well as distinct states of activation, including fight, flight, freeze, or fawn. In secondary structural dissociation, cognitively and consciously, the person feels they are one individual, but emotionally and unconsciously, these several emotional parts contribute to the person's emotional landscape. What is complex PTSD? Complex PTSD results from exposure to severe stressors that are 1, repetitive or prolonged, 2, in children involve harm or abandonment by caregivers or other ostensibly responsible adults, and 3, occur at developmentally vulnerable times in the victim's life. Like PTSD, people with complex PTSD feel a sense of threat, re-experience the trauma in the form of flashbacks, and avoid potential triggers. In addition, people with complex PTSD also experience affect dysregulation, negative self-concept, and interpersonal disturbances, all of which are often not present in PTSD. Complex PTSD is included in the ICD-11 diagnostic system, but not in DSM-5. This omission was explained in that supposedly there's not enough evidence to differentiate PTSD from complex PTSD. Many trauma experts disagree with this. Complex PTSD does significantly overlap with two DSM-5 diagnoses, reactive attachment disorder and disinhibited social engagement disorder. Complex PTSD overlaps both with PTSD and borderline personality disorder. The diagnosis of borderline personality disorder seems to combine symptoms of PTSD and features of a disorganized attachment style. As we saw earlier, PTSD involves re-experiencing the trauma through flashbacks and nightmares, avoidance, numbing, and dissociation, as well as hypervigilance. Complex PTSD, in addition to all the features of PTSD, also involves self-harm, an unstable sense of self, difficulties with emotional regulation, difficulties with the relationships, and a negative self-concept. Borderline personality disorder involves these later features of complex PTSD, but in addition, also suicidal behavior, efforts to avoid abandonment, and shifting self-identity. To watch a video entitled Signs You Have Complex PTSD, please go to the website now. Primary structural dissociation is PTSD. Secondary structural dissociation is complex PTSD. What is tertiary structural dissociation? Tertiary structural dissociation is dissociative identity disorder, which is formerly called multiple personality disorder. According to structural dissociation theory, in tertiary structural dissociation, there is such an imbalance between the severity and duration of the trauma and the available coping resources that the emotional mind's dissociative coping mechanisms are insufficient to protect the self from the trauma, and the apparently normal and conscious self also split or fragment. This creates two or more conscious mind parts or alters that have distinct personalities and states of activation. Each alter of the apparently normal part may have a function in the overall personnel system. For example, one goes to work, another socializes, others protect the person. In only 5% of dissociative identity disorder patients is there blatant switching of parts, usually when there's comorbid histrionic personality, making it easy to misdiagnose since behavior changes can be very subtle. Dissociative identity disorder is at the frontier of our understanding of the trauma spectrum disorders, and perhaps because of that is a subject around which there is much debate and controversy. Imaging studies have compared dissociative identity disorder individuals to actors and studied alters who are blind while the main personality is not. While some experts consider all parts present in primary, secondary, and tertiary structural dissociation as being on a dissociative spectrum, others differentiate ego states in which parts retained a shared sense of belonging to a person as a whole and are less distinct, autonomous, and amnesic, and dissociative states in which each part has its own sense of identity with discrete self-representations, autobiographical memory, and personal experiences, or a sense of I, me, and mine. In dissociative identity disorder or tertiary structural dissociation, the emotional parts become alters. Just as there are common emotional parts, there are common alters. People with dissociative identity disorder present with a number of characteristic symptoms, including hearing internal voices, having intrusive thoughts, feelings and urges, identity confusion, amnesia, and feeling like different people. Common types of alters in dissociative identity disorder include the host, child alters, internal self-helpers, opposite sex alters, persecutors, protectors, sexual alters, suicidal alter, and teen alters. Less common alters include an animal alter, baby and infant alters, caretaker, demonic, military or political alters, non-human alters, robot or machine-like ones, and supernatural alters. Aren't there some controversies around the diagnosis of dissociative identity disorder? Yes, there are. In this course, we support the post-traumatic model described on the left hand of the slide. The social cognitive model is, however, supported by many authorities in the field. It suggests other possible explanations for dissociative identity disorder, especially iatrogenesis and pseudogenesis. The trauma model of dissociative identity disorder holds that children learn to dissociate to repress traumatic memories. The iatrogenic position of the social cognitive model suggests that therapists induce dissociative identity disorder by presuming the disorder and influencing clients that want to please the therapists. The pseudogenic position suggests that people simulate dissociative identity disorder without therapeutic intervention for secondary gains, such as being found not guilty of a crime. To watch a video entitled Dissociative Disorders, please go to the website now. If PTSD, complex PTSD, and DID are all part of the dissociative spectrum disorders, are the treatments for them similar? There are many similarities. For instance, we have to consider 3 stages in the treatment of all the trauma spectrum disorders. Before I talk more about the 3 stages, let's, however, consider some of the factors involved in the treatment of these disorders. Today, in the field of dissociation and trauma spectrum disorders, there is more scientific knowledge, public awareness, and peer initiatives than there's ever been. But there is also a great lack of well-trained trauma treatment providers, programs, and resources. We are in a situation akin to that which the treatment of acute lymphocytic leukemia, the most common type of childhood cancer, was in the 1970s when it had a 90% mortality rate. Today, the mortality rate has dropped to 10%. This is not because we have any new treatments. We are still using the same ones we did 50 years ago. What has changed is that we're much better at using these treatments in a uniform way. Similarly, with dissociative and trauma spectrum disorders, if we were better at using the treatments we've known about for 100 years, effectively, we'd have much better outcomes. In this segment of the session, we'll explore 3 phases of treatment for dissociative trauma spectrum disorders. Keep in mind that treatment needs, of course, to be individualized for each person. For instance, people with single event PTSD who have good resources may not need to spend a lot of time in phase 1 of treatment, which involves stabilization, and may be able to proceed directly to phase 2, which involves processing the trauma. On the other hand, people who have fewer resources may need to spend considerable time in phase 1 stabilization. People who have significant psychosocial developmental issues may need to spend considerable time in phase 3, which involves resuming psychosocial development. We will explore how specific treatment issues arise in each of the 3 types of structural dissociation. For example, shame is an important consideration in secondary structural dissociation / complex PTSD. We'll explore why. In the next 2 sessions, we will discuss wise mind remediation and internal family systems, which are both phase 2 trauma processing approaches. The various treatment approaches for the trauma spectrum disorders can be conceptualized as either bottom-up or top-down. The bottom-up approaches are those approaches that target primarily the body and emotions with their interventions and only secondarily affect the rational mind. The top-down are those approaches that target primarily the rational mind and secondarily affect the body and emotions. Ideally, trauma treatments incorporate elements of both. Bottom-up approaches include yoga, martial arts, meditation, and EMDR, while top-down include cognitive behavioral therapy and dialectical behavioral therapy. Bessel van der Kolk has written the classical text on the trauma spectrum disorders and their treatment, entitled The Body Keeps the Score. He discusses both top-down and bottom-up approaches and their role in the treatment of the trauma spectrum disorders. Let's now discuss some general principles in the treatment of dissociative and trauma spectrum disorders. Treatment approaches for the dissociative and trauma spectrum disorders have not changed much since the time of Pierre Janet. There are three phases to the active stage treatment of trauma spectrum disorders, be they primary, secondary, or tertiary dissociation. Phase 1 is safety and stabilization. Phase 2, remembrance and mourning. And phase 3, reconnection. If people are pre-contemplative, they may not understand that their symptoms and distress are in part the effects of their past on their present. They may believe the problem is with the world, others, social systems, or healthcare providers, not with them. If people are pre-contemplative, psychoeducation is critical. Reenacting traumatic issues with healthcare providers who are not trauma-informed is not helpful for the person. DBT and CBT are mostly phase 1 therapies. Simple uses DBT and CBT phase 1 strategies. Simple's internal family systems, wise mind remediations, and editing, splicing, and pasting are phase 2 strategies. The Goals Diary Card procedure is a phase 3 strategy. Judith Herman, one of the pioneers in the recent resurgence of interest in the trauma spectrum disorders, has summarized the aims of each of the three phases of trauma treatment. She calls stage 1 establishing safety. The goal of stage 1 are to make sure the person is safe, stabilize symptoms, and promote self-care. Stage 2 is remembrance and mourning, during which the trauma is revisited and transformed. Stage 3 is reconnection, in which empathy for the self is promoted, as is reconnection with others and becoming a survivor rather than a victim. This complex slide describes in greater detail the work to be done at each of the stages of trauma recovery. In the slides that follow, we will consider each of the stages individually. Note the warning that recovery is not linear. A person's journey will also not follow a straight line, but instead might be circular, moving in and out of stages until they feel they are ready to move forward and reconnect with their goals and dreams. Stage 1 is education, stabilization, and safety. Education helps normalize doubts. Your nervous system and brain are responding exactly the way they were designed to respond after having survived repeated traumatic experiences. Two sets of goals that are typically worked on in this stage with the help of a counselor, caseworker, or other helping professional are basic health needs such as regulation of sleep, eating, exercise, abstinence from drugs and alcohol, and destructive behaviors, and basic environmental needs such as physical self-protection, work and income, and secure living situations. Stage 2 is trauma processing, remembering, and mourning. The therapist works with you on going through all the traumatic memories and taking the incoherent pieces and working them into a more coherent whole. In this stage, cognitive-based approaches, along with somatic ones, work best to release body memories and reduce the number of triggers. This work proceeds in small steps. Memories are likely to evoke intense emotions. The goal is integration, not catharsis. Stage 3 is meaning and reconnection. This stage is where inner healing is especially helpful in identifying faulty coping mechanisms and lies that are believed and dealing with existential questions like, why did God allow this to happen to me? Why am I here? And what does it all mean for me? It's also a stage where work is done on expanding friendships and intimate relationships and repairing family relationships. Each of these stages can last from months to years, depending on the severity, duration, and age of onset of the trauma. People may be done with recovery after stage 1 or stage 2, based on their personal comfort level and goals. Let's now review each of the stages of recovery from trauma in more detail. The first stage in the healing of trauma spectrum disorders involves 1. Developing a personal roadmap of the healing process. 2. developing realistic and attainable goals, and setting up a plan of action for achieving these goals in a practical time frame. Three, establishing a sense of stability and safety in interpersonal relationships, one's own body, and all other areas of life. Four, learning how to regulate emotions and how to manage psychological and behavioral symptoms that may contribute to a sense of instability and overall personal suffering. Five, beginning to recognize and tap into resources as inner strength. Six, developing crucial coping mechanisms and life skills geared towards effectively managing painful experiences and regulating emotional, mental, and physical responses. Practically, stage one stabilization goals include reduction and elimination of drug and alcohol abuse, promotion of good health, safe housing, adequate income, adequate transportation, and setting and keeping a healthy schedule. The main goals of stage one are developing a sense of personal safety, cultivating a crucial self care routine, and learning to regulate emotions and behaviors in a healthy and efficient way. Once these necessary skills become fully integrated into your life, you will be able to work through painful memories with far less mental and emotional repercussions. It is, however, not always necessary for everyone to do the stage two work of processing traumatic memories. Phase one treatment, stabilization, can be lengthy in people who have prominent dissociative features. When people start working on phase two or processing trauma, which can trigger dysregulation, they need phase one stabilization skills to pendulate back to the window of tolerance. Stabilization skills include one, learning to observe somatic sensations. This is a somatic experiencing technique. Two, developing and installing resources. This is done in approaches such as EMDR through resourcing, which refers to identifying and instilling coping resources that help you to deal with difficult situations. It is also part of DBT skills. Three, developing spiritual resources. Four, building social supports. Five, engaging in pleasant activities. Six, healing the brain using neurofeedback. Empirically supported treatments for stage one include DBT, mindfulness based stress reduction, cognitive behavioral therapy, imagery rehearsal therapy, and motivational interviewing. Resources which are developed in stage one are critical to stage two work. In trauma therapy, a resource is anything that helps the therapeutic process. Resources can be supportive friends, therapists, therapy animals, learned skills, etc. Resources help bring people back to the window of tolerance. When processing trauma, it is critical that the person stay in the window of tolerance. All trauma processing strategies involve some kind of imaginal, real life, or virtual exposure to implicit and or explicit traumatic memories with pendulation to resources when the person is leaving the therapeutic window. Thus, pendulation between trauma and resources. Dual focus, or the shifting of focus between trauma and resources, is the common factor of many phase two approaches, including EMDR. This is why phase one work, which fosters resources, is so important before embarking on processing trauma. If you try to do phase two work, but don't have resources to help bring you back to the window of tolerance, exploration of associated traumatic memories will only further re traumatize you. Stage two of trauma recovery is frequently referred to as remembrance and mourning. Once an individual has developed a strong and functional set of coping skills and feels reasonably safe and secure in their surroundings, it becomes possible to address long buried memories. The main work that the second stage of trauma recovery involves one, discussing and evaluating painful and traumatic memories with the intention of restructuring the role they play in people's lives. Two, working through trauma related grief brought about by unwanted or abusive experiences and the impact they had and continue to have on people's lives. Three, mourning the loss of good experiences that have not yet occurred or did not have the chance to occur because of persistent trauma related symptoms. 4, discussing painful memories is not always necessary to achieve the personal goals established in the first stage of trauma recovery. Remember, stages will vary depending on personal history and personality. Some people may find that memories that were once perceived as too painful to examine are no longer causing any grief or inner turmoil. 5, if memories are still disruptive and have been found to continuously pose a threat to long term recovery from related issues, there are several memory processing methods that can be employed during this stage of recovery, such as EMDR and sensory motor therapies. The third and final stage of trauma recovery focuses largely on reconnecting with people, personally meaningful activities, and all other aspects of a fulfilling and healthy life. During this stage, you will need to develop a new sense of self. Traumatic experiences will no longer play a defining role in your life. You will be mentally and emotionally set free from the painful and limiting chains of the past. Steps towards self actualization and empowerment will be taken, and the human spirit, in all its awe inspiring resilience, will begin truly and thoroughly recovering from the devastating effects of traumatic experiences. It is important to keep in mind the fact that recovery is a highly individualized process, and it will look quite different for every unique individual. It is common for those who have suffered at the hands of trauma to want to feel better as quickly as possible. However, recovery from anything is a process, one that requires both consistency, commitment, and self compassion. Recovering from trauma does not mean you will be completely free of intrusive thoughts or feelings. Rather, you will reclaim your life, love, and your authentic self. The previous slides described the general type of work to be done at each of the stages of treatment. Can you tell us about the specific therapeutic modalities that are helpful at each of the stages? Many different approaches have been used to treat trauma spectrum disorders, including medication, psychotherapy, alternative treatments such as yoga and acupuncture, virtual reality exposure, and psychedelic assisted psychotherapy. Before we consider the various psychotherapeutic modalities, let's compare psychotherapy with medication treatments in PTSD. Studies have compared the benefits of psychotherapy to those of pharmacotherapy and contrasted these to people receiving no treatment. Psychotherapy has been shown to be of greater benefit than pharmacotherapy. Carefully combining psychotherapy and pharmacotherapy may, however, yield the best results. First line psychotherapies for PTSD include prolonged exposure, cognitive processing therapy, and EMDR. Other approaches that have been shown to be of benefit include cognitive behavioral therapy for PTSD, narrative exposure therapy, and brief eclectic psychotherapy. Commonly used medications for PTSD include SSRIs, the alpha blocker prazosin, mood stabilizers such as valproic acid, and antipsychotics such as Abilify. This slide lists the evidence-based approaches in the treatment of the traumatic spectrum disorders. The slides following this one describe each model in slightly greater detail. Evidence-based psychotherapies for PTSD include skills training in affective and interpersonal regulation, cognitive therapy for PTSD, narrative exposure therapy, prolonged exposure therapy, brief eclectic psychotherapy for PTSD, cognitive processing therapy, and eye movement desensitization and reprocessing therapy. Prolonged exposure therapy sees fear as a normal response to the trauma. Fear, anxiety, and social conventions lead to avoidance. Avoidance tends to get reinforced. Avoidance prohibits emotional processing. Emotional processing requires 1, activation of the traumatic memory, and 2, corrective information. Brief eclectic psychotherapy for PTSD is a manualized, multimodal, 16-session combination of psychoeducation, cognitive behavioral, and psychodynamic elements. It provides psychoeducation exposure through guided imagery, writing tasks, working with mementos, finding meaning, and integration, and ends with a farewell ritual. Narrative exposure therapy provides psychoeducation and helps a person write their biography, which contains a detailed account of the traumatic experiences. It uses this biography for political and social purposes. From fragmented biographical memories, through this process, a coherent narrative is created. It helps people to integrate and habituate to past fears. The unspeakable terror in the here and now is transformed into a past that can be put into words, that was experienced at a different time in a different place. Cognitive therapy for PTSD develops for each person a unique case formulation. It updates trauma memories by accessing memories of the worst moments during the trauma and eliciting their current threatening meanings. It identifies information that updates these meanings. It then links the new meanings to the worst moments in the memory. It also uses behavioral experiments to help reduce unhelpful behaviors and cognitive processes. Cognitive processing therapy typically consists of 12 sessions of either individual or group therapy. It is a trauma focused cognitive therapy focusing on Socratic questioning of assumptions and beliefs arising as a result of traumatic events. It first focuses on the trauma itself and then on dysfunctional beliefs that arose from the trauma regarding a number of subjects. Between sessions, patients are asked to write down detailed accounts of their worst traumatic events and read it to themselves. It uses structured worksheets and other written materials. EMDR is typically divided into 8 stages. 1, treatment planning, where a history is taken and a list of traumatic events created. 2, the preparation phase, where a safe place is selected and self-controlled techniques learned. 3, the assessment phase, where a traumatic memory is chosen to be worked on and an image from this traumatic memory selected. The best fitting negative thoughts associated with this image are selected, as well as positive cognitions. 4, desensitization, which includes bilateral stimulation to neutralize the traumatic image. 5, installation, where the positive cognition is installed with the help of bilateral stimulation. 6, body scan, where residual tension in the body is identified and reprocessed through the procedural outlined above. 7, closure, when a return to a state of equilibrium is achieved. Self-control techniques need to continue to be applied. 8, the reevaluation stage checks if the traumatic memory that was selected is still upsetting. If so, EMDR resumes at step 4. Virtual reality exposure has been widely used with combat veterans. It combines a graduated virtual exposure with traumatic triggers, pairing this with relaxation and cognitive reframing techniques. Psychedelic-assisted psychotherapy is an emerging field for which there is much enthusiasm and great potential. Some of the substances that have been used include MDMA, LSD, DMT, psilocybin, ketamine, and mescaline. Over the past decade, there's been an increase in the clinical trials testing these agents for use in psychiatric conditions, including depression, drug dependency, anorexia nervosa, end-of-life depression, and the PTSD spectrum disorders. There are now many studies of psychedelic-assisted psychotherapy. To give you a sense of the promise of the studies, let's just look at one study with fairly typical results for this type of intervention. In one study using MDMA-assisted psychotherapy, 67% of patients who had 3 sessions of this approach no longer met the criterion for PTSD diagnosis. Neurofeedback is an underutilized, very promising approach to emotional dysregulation. It assesses patterns of brain function, detects abnormalities, and trains through video games those parts of the brain to revert to more typical functioning. Seaburn Fisher, a psychologist who happened to be hospitalized at the Institute of Living at the same time as Marshall Linehan, wrote the seminal book on neurofeedback in the treatment of trauma. Although there are many different approaches to the treatment of trauma, many of these approaches share common elements. including emotional regulation techniques, skills training, exposure, and meaning making. So far, there are no evidence-based psychotherapies for phase 3 of trauma therapy. Because it is the most severe form of structural dissociation, the treatment of dissociative identity disorder is the most challenging. Experts agreed that there are three main goals in treatment of DID. One, cooperative arrangement between alters or parts. Two, partial integration. And three, final fusion. Integration in this instance is a broad process referring to all work on dissociative processes during treatment. Fusion, on the other hand, refers to a point in time when two or more alters join together with a complete loss of subjective separateness. Final fusion refers to the point in time when the patient's sense of self shifts from that of having multiple identities to that of being a unified self. One, to achieve cooperative arrangements between the alters. Sufficient integrated and coordinated functioning among alters promotes better functioning. Two, partial integration, which includes fusion of some parts as well as cooperative functioning. Some alters join together and there's no sense of separateness between them. At the same time, other alters function in a cooperative and coordinated way. Three, final fusion or complete integration is the complete merger and loss of separateness of the alters. This is the most stable treatment outcome. Most DID patients won't achieve this or even find it desirable. Because there are so few therapists who specialize in the treatment of DID, it is extremely difficult to access expert effective treatment. In the treatment of dissociative identity disorders, the goal is to integrate functioning and or promote harmony between the different alters. Can you tell us more about how Simple addresses the three stages of trauma treatment? Stages 1 and 2 of trauma work focus on the bottom half of Maslow's pyramid, meeting physiological and safety needs and staying safely in the window of tolerance. Stage 3 work focuses on top half of the pyramid, developing connections, self-esteem, and a sense of meaning. Freud saw man as primarily seeking pleasure, Nietzsche as seeking power, and Viktor Frankl as seeking meaning. All these three thinkers were actually describing different aspects of Maslow's hierarchy of needs. The Goals Diary card procedure outlines our various needs, helps us assess which are and aren't met, and helps us set up a systematic approach to pursuing these needs. Stage 3 work pursues establishing a meaningful life through connections. It focuses on the upper half of Maslow's pyramid, or love and belonging, self-esteem, and self-actualization. Stage 3 fosters psychosocial growth through Erikson's stages of achieving a healthy identity, the capacity for true intimacy, the desire to give back to the world, and to find meaning in life. This requires stage 1 and 2 work first. The 8 dimensions of wellness span all the needs on Maslow's hierarchy. The ultimate goal of trauma spectrum therapy is to allow people to have all those needs met. Clearly, the treatment of trauma spectrum disorders is quite complex. Is there anything else we might have left out that you think is important for us to know? One special topic that warrants mentioning in the treatment of traumatic spectrum disorders is shame. Shame can be defined simply as the feeling we have when we evaluate our actions, feelings, or behaviors and conclude that we have done wrong. Shame encompasses the whole of ourselves. It generates a wish to hide, to disappear, or even to die. Shame is the feeling of inferiority. Shame is the belief in one's inferior status or the feeling that one does not conform to social norms and expectations. Shame is a feature of complex PTSD. Enduring prolonged abuse, whether it be by a caregiver, partner, relative, or coworker, leaves the person with a false internalized belief that they are innately bad, defective, and not good enough. Shame is associated with trust issues, being a people pleaser, self-sabotage, feeling undeserving of love, never feeling safe, feeling as if you have to be perfect, constantly feeling like you've done something wrong, and a chronic sense of worthlessness and not being good enough. People experience external shame in the form of thoughts and feelings about how they exist in the mind of others, and internal shame or self directed evaluations, thoughts and feelings about inadequacies and flaws. Shame often arises in the context of attachment issues, and especially when there is trauma perpetrated by a caregiver. When most of us consider an abused child, we think the child does not deserve the abuse. We consider the problem to be with the abuser. That is because we think about the situation with our rational minds. If, however, as adults, we are in an abusive relationship, over time, we often come to believe that the problem is with us. This is what happens with gaslighting or the Stockholm syndrome. That is because we come to feel the situation from emotional mind, and emotional mind dominates rational mind. The emotional mind is fully developed at birth. The rational mind isn't. It starts to develop only at ages 3 or 4 and is only fully developed by our mid 20s. The abused child doesn't have the capacity to think of their situation from rational mind. They can only feel the situation. The model that forms in their mind is that one, an all knowing, all powerful adult who is angry at them and repeatedly holds them at fault, and two, their frightened or despairing and abandoned selves. Shame, the feeling that there is something fundamentally wrong, evil, unlovable, not good enough, or different, and that I will be abandoned, in danger, unhappy, and that it is my fault, is born in this caregiver child dynamic. This deep rooted feeling is resistant to change by rational mind reframing. This kind of shame is extremely important in people with attachment and developmental issues. Shame is an important consideration in psychotherapy. Shame often results in people stopping or never engaging in treatment. Shame impedes social connections and cuts the individual off from the support and soothing that may come from others, including therapists. The power imbalance between patients and therapists and the unilateral exposure of the patient's most intimate thoughts and feelings can further contribute to a feeling of shame in therapy. Lack of trust, present in complex PTSD, starts with early attachment issues and the failure to negotiate Erickson's stages of trust versus mistrust. The development of a trusting and secure relationship, whether it be with a mentor, friend, partner, or therapist, is key in the repair of shame. The other subject that is important to mention is re-traumatization in the context of relationships or systems such as the healthcare system. The solution to re-traumatization in healthcare is trauma-informed care. Re-traumatization happens when a person suffering from a traumatic spectrum disorder is exposed to people, incidents, or environments that cause them to relive the previous trauma, almost as if they were all occurring again. Because we are drawn not to relationships that are good for us, but to those that are familiar, re-traumatization is common. In a therapeutic setting, transference and countertransference can result in re-traumatization. Re-traumatization often affects vulnerable people in contact with healthcare settings. Re-traumatization can be prevented through trauma-informed care. The solution to re-traumatization is trauma-informed care. Trauma-informed care involves a few key considerations. One, ensuring the traumatized person's physical and emotional safety. Two, giving individuals control and choices. Three, making collaborative choices with the individual. Four, being clear, consistent, and having good interpersonal boundaries. Five, prioritizing empowerment and skills building. Finally, here are three books that might help you to better understand the traumatic spectrum disorders and their treatment. On the PowerPoint presentation that you will find on the website, there's a review and practice component that covers the tools, techniques, and strategies that we have previously covered in the simple course. Looking over those slides will help you consolidate the material. Let's look at the homework for this session. Thank you for spending this time with me today, and see you next session.